Hello, good afternoon, everyone. Hello, good afternoon. Welcome everyone to our webinar today. That is Bedside Advanced Lung Monitoring, Exploring Ventilation and Perfusion with Electrical Impedance Tomography. We are extremely excited to have all of you here with us today as we will dive deeply into how electrical impedance tomography can transform our understanding of ventilation and perfusion dynamics at the bedside. And today, we have here Professor Marcelo Amato. Professor Marcelo Amato, we have this great privilege of learning with Professor Amato, that is Chief of the Respiratory ICU at the University of São Paulo. He's also visiting professor at Beth Israel and associated professor at Harvard Medical School. And as all of you should know, Professor Amato has revolutionized the field of mechanical ventilation actually setting new standards in lung protective ventilation through his pioneering research. And his contributions have transformed critical care practices, improving outcomes for patients all around the world. And in this session today, Professor Amato will walk us through the latest advancements in EIT technology, showing how real-time insights into ventilation and perfusion can support more personalized and precise patient care. So thank you all of you for joining us today. I really look forward to an enlightening session with Professor Amato and with each of you. So thank you very much for joining. And Professor, please, the stage is yours.
Okay. Thank you, Neto. Thank you for this nice introduction. Let me share this screen. So good morning or good afternoon for everybody. We are going to discuss ventilator monitoring and perfusion monitoring with EIT, and this new feature, which is the VQ map. I'm very glad to testify that this is already being used at the bedside. And it's a long quest in the last years to have the technology available at the bedside. So I'm very happy to share this. A long time ago, CT perfusion was described, a dynamic CT perfusion, based on the first passage contrast map. Basically, you inject a bolus of contrast and you track this passage of the contrast through the lung, like in this video. So let's do it again. So we see that we see the enhancement of densities of the lung during the passage of the contrast. It takes about 5 to 10 seconds, and the density of each pixel obeys a curve, more or less like this. Typically, the contrast has a very high density, and when it's diluted in the lung, it causes an increase in densities, about 50 Hounsfield units for each pixels. And then what happens is that the pixels in which you have highest perfusion, you see a higher increase in density, like in this particular pixel here in the image. So when you see this curve, you can observe that this curve has a higher slope and a higher amplitude. You can pick up one of both, the slope or the amplitude, and there is some demonstrations that the slope is even better than the amplitude to track the perfusion in each pixel of the image. Using the same principle, we will try to apply the same method using EIT. But just before going through this, I would like to remember you that using this dynamic CT analysis, we, for instance, could demonstrate that perfusion is predominantly dorsal in animals or human beings, even when the animal is in prone position. You can see here that independently of gravity, and this is a common misunderstanding, people believe that perfusion obeys gravity because this is an old statement from John West. But in the particular case of the change from prone to supine, this is not true. And then, for instance, the first person that applied this principle was Brian Brown. And he tried to follow this perfusion in the lung. And you can see that the technology at that time had a very bad signal-to-noise ratio, and the signal was very noisy. But in the last years, we are very glad to see that the resolution of EIT nowadays allow us to study perfusion with a very reasonable precision. Typically, this is the signal of a plethysmogram of a patient in the ICU. This is the ventilation signal. And then we stop. We perform an apnea using an expiratory pause. And then we inject a saline. Nowadays, many different concentrations of saline have been studied. Typically, you have been using 7.5%, 10 mLs, but many papers nowadays are using 10 mLs with 10% saline solution with a good safety record. Then those oscillations in the impedance are used to calculate ventilation, and especially the maximum slope of the pixels during this drop in impedance caused by the saline. They are used for studying perfusion. This method was very well described in this paper in Journal Applied Physiology in 2013. And in this paper, we described the method very precisely, and also including the fact that in most cases, you have some mixed signals coming from the heart and then the lung perfusion. And then you have a bimodal curve that you have to decompose to have the precise perfusion of the lung. This is very important because in many papers in the literature, we have seen some perfusion maps in which the researchers, they did not decompose the signals. And sometimes if you do not do this, you wrongly estimate a high perfusion in the heart area. This is because the contrast, they goes twice through the heart. As you can see in this video, we inject the saline in the right atrium, and then we see the saline moving towards the lung and then back to the heart, like in this sequence. First, the contrast is in the right atrium, then right ventricle, pulmonary hilum, both lungs, and then back to the atrium. So if you do not decompose and isolate only the lung part of this whole sequence, you are going to overestimate the perfusion in the ventral parts of the thorax. And we have seen many papers in which this was not taken into account. Nowadays, we decompose the heart passage in blue, because then it gets easier for the physician to isolate and visualize the component of the lung. In this case, the lung component now is in a different color, as you can see here. In this paper, we validated the method and we proved that this method is proportional to what we call lung perfusion and not lung blood volume. The difference is that, for instance, if we go to the new technology called dual source CT, which is a method that has been claimed to analyze, to measure lung perfusion. In fact, this method measures lung blood volume. And this is very important because in many clinical conditions, the blood volume and blood perfusion, they can be a little bit dissociated. So when we are measuring EIT perfusion, it's really perfusion, it's not blood volume. We have compared this method with gold standards. I'm going to present you two important studies. The first study we did in 2013 was against SPECT. In this case, we had a bilateral perfusion, very well preserved in presented in EIT and in SPECT. A good agreement of the perfusion of the left lung. Let me just have a little bit more contrast for my pointer. And then we performed a selective intubation with hypoxic vasoconstriction. Then the perfusion in the left lung decreased, as shown in both methods with a good agreement. And finally, we gave nitroprusiate, which works as a blocker of hypoxic pulmonary vasoconstriction. And then the perfusion got back not exactly to normal, but almost normal values, despite the fact that this lung remain atelectatic and hypoxic. So one question, an important question, is the representation involved in the EIT image. I mean, which part of the lung are we representing? We know my mouse is, okay, got stuck. Okay, so typically we put the belt in a cross-section of the lung. And then one important question is to understand how thick is the slice. Part of this thickness is related to the model of the lung that we use, and this is related to a finite element mesh. In this case, the mesh is a little bit thinner, but we can use more complex meshes, which have been proposed nowadays, representing almost the entire length of the lung. You can see here in the image that in this particular case, the model used for EIT reconstruction embraces the whole lung, like this also. And then it's important also to consider the position of the electrodes, as you can see here. But this is not the only problem. Part of the problem is also how the current is spread across the thorax. And for instance, there is some debate how much the current is spread, like in a sphere, because the conductivity and the electrical current goes like in a sphere when you put this belt in a model like the thorax. So then the question is, how thick is this slice for clinical purposes? We did 2 studies to understand this question. So how large is the cranial caudal representation of the lung? We did 2 studies. In these studies, we did an inspiratory pause, an expiratory pause. We have a CT evaluation here, CT evaluation here, and then we subtracted both CTs. And then we have whole lung CT, and we compare this whole lung CT with EIT. So you have the CT during inspiration, during exhalation, we subtract. So those white zones are the zones in which we have different aeration in pixels, comparing this image with this one. So we have much more air coming here in dorsal lung regions than ventral. And then we have the EIT image, and then we compare this distribution against this distribution. Very dorsal, very dorsal. Very ventral, ventral. Homogeneous, homogeneous. So then we compare with different, let's say, slice thickness using, because in the CT, I can choose how many slices I put together to do the analysis. With EIT, we have only one big slice. And then the question is, which is the best agreement between EIT and a certain slice thickness in the CT image? And we can see here a slice of 5 centimeters, 10 centimeters thick, 15, 20, 25. And then we can see that the best agreement with EIT is when the slice has 15 centimeters. You understand why this is very important. And this is true when considering ventral to dorsal relationships, right to left relationships. And also in peaks, we compare whole lung, 10 centimeters, 5 centimeters, and 15 centimeters. And again, the best agreement with with more precise limits of agreement was found when the slice thickness was about 15 centimeters. So you can consider that whenever we see an EIT image, we are observing a slice thickness of about 15 centimeters. This is not 100% precise, because, for instance, if you have a small baby, the belt is almost covering the entire lung. Or if you have different models, or if you put your electrodes in different positions. And for instance, now the new belt for Timpel is going to use a different configuration, and then the slice thickness could be a little bit larger. But if you think about a thorax of a baby like this, and you have electrodes like this, the slice thickness is going to be almost the entire length of the lung in terms of cranial-caudal distance. Why I'm talking about this? Because now let's see some recent studies that we did about perfusion. In this particular case, we did perfusion in a pig model of pulmonary emboli. This is the angiography of a vascular tree of a pig. This is the pulmonary artery. Here, these upper vessels, and these other vessels here are the venous return, are the venous part of the arterial tree, of the pulmonary artery tree. And then we are going to block, for instance, the left lung using a Swan-Ganz catheter. We can see here now that this vessel is empty, and the balloon of the Swan-Ganz is here, okay? So now let's change the position of the balloon. You can see here the Swan-Ganz. This is the tip of the Swan-Ganz. Now the tip was moved to a more proximal position, and this is the balloon. So in each animal, we put the balloon in multiple different positions. This is more distal, more proximal, to the other side. And then we checked what happened with dynamic CT, with a bolus of contrast, and with EIT. So this is the dynamic CT image. which is representing a slice thickness of 3 centimeters. So this is a very thin slice. This is the CT image. You see that the left lung is a little bit whiter because there is more perfusion in this lung than in this lung. Precisely because the swan guns, the balloon was in the right side. Then we see the perfusion only in the left side. How much? 96%. Okay, then we compared with EIT. This is the EIT image, 94%. So we did this comparison for multiple occlusions, but think about the following. This is a 3 centimeters thick. This is a 15 centimeters thick. So we cannot expect a perfect agreement because this is representing a larger part of the lung. But let's see the results. Interesting, in this particular case, the ventilation was bilateral. And we can see that both lungs were aerated because the pathology here was just a model of pulmonary emboli caused by the Swan-Ganz catheter. So we had unilateral perfusion, bilateral ventilation, as shown here. And nowadays, we are trying to superpose these two images to provide a map for the physician, like in this case, represented here. We have the ventilation map, the perfusion map, and then we put one on top of each other. And for clinical purposes, we just represented 3 colors because they are 3 basic clinical conditions for the lung physiology. Green means that I have, let's say, good perfusion and good ventilation. Blue means that I have much more ventilation than perfusion. And red, which I have only 1 dot here, means that I have more perfusion than ventilation. So we are superposing the 2 maps. And this is now provided in the online software of the EIT. So let's go back to our experiment and check what we got when using this model of pulmonary emboli. Remember, we caused some distal occlusion, which should block this part of the lung. And we cause proximal occlusion, which should block this part of the lung. And then we can think that we can compare the results of the EIT with another method of measuring the degree of occlusion or the degree of perfusion impairment, which is something used clinically for radiologists, which is the clot burden. Clot burden means you try to estimate the percentage of vessels that are occluded by your perturbation or by your emboli. For instance, in this case, we have 0 and 0. So 0 vessels among 17, 0 vessels among 14 in the left side. But here, we did the counting, and we have 6 vessels occluded against 17 in total for the right lung, and 0 for the left. And in this case, we have a higher percentage because you have 12 occluded vessels among 14. Now we can compare this percentage against the EIT. And our hypothesis was that this kind of evaluation and quantification should have a better match with EIT because this is representing almost the entire lung. And there is very few vessels here in the apex, which are far away from the electrode belt. So we made the hypothesis that this kind of evaluation should have a better agreement with the EIT evaluation. And this was exactly the case. This is the correlation with dynamic CT, a thin slice. So the R, the coefficient of correlation was 0.95 with reasonable limits of agreement. But once we use the clot burden, which represents almost the total lung, a thicker slice of the lung, then the correlation got even better with a best agreement among all, and also a better limits of agreement. And so this best agreement can be explained by the fact that the clot burden is really representing almost the entire lung, with the exception of the vessels placed on located in the apex of the lung. Okay, using this approach, then we checked our results, and somehow we tested not only the degree of occlusion of vessels, so the clot burden against the perfusion distribution, but then we decided to do something, to move a step forward. Let's see how good we are in detecting pulmonary emboli, and how we are going to define pulmonary emboli. We have the Swan-Ganz, and we know when we have a complete occlusion of that vessel, because we have the wedge pressure, wedge traces in the Swan-Ganz. And at the same time, we had the angiography, and then we had a radiologist measuring the clot burden. So then we knew, okay, this patient has or doesn't have a pulmonary emboli first. And then where is the pulmonary emboli, right or left? And then we tried to correlate this pulmonary emboli with some measurement of dead space in this image. Dead space here would be something in blue colors, right? Because it would be a region in which I have mostly ventilated pixels, but not well perfused. So when we didn't have any occlusion, this is a typical image. We have a little bit of shunt in this case, but then we did a complete occlusion, but this, it was a right proximal occlusion, and we can see a big blue zone here because perfusion was blocked here with a preserved ventilation. Then we did in the other side, a big block in perfusion in the left side, you can see here. And then we tested the specificity of this impairment in perfusion, for instance, doing a bronchial occlusion, mimicking a pulmonary pneumonia or some problem or some blockage of by secretions. We see an impairment in ventilation, a small impairment in perfusion caused by hypoxic vasoconstriction, and then we checked our image. We were afraid that we could, let's say, falsely detect a pulmonary emboli because of this block in perfusion caused by hypoxic vasoconstriction. But the interesting finding is that this mapping helped us to detect a completely different problem. We can detect that here we have a problem of pulmonary shunt and not of pulmonary emboli. So this, let's say, this situation of impaired perfusion in the left lung was completely, let's say, it was differently, gave us a completely different scenario than this one. I still have an impairment in the perfusion here, but the ventilation was preserved, and then I could detect a high suspicion of pulmonary emboli. But in this case, perfusion was blocked, but because of hypoxic pulmonary vasoconstriction, and then the superposition of the two maps, helped us to detect that the clinical problem was very different. So the problem here was much more a shunt problem. And we did these occlusions of the bronchial tree using multiple FiO2. This is a low FiO2, so you have low perfusion, complete blockage of the ventilation in the left lung, and the EIT detected only shunt problems. Despite this very low perfusion, so EIT was not indicating any suspicion of pulmonary emboli, but indeed of pulmonary shunt. So it was a problem of ventilation, not of perfusion. And then we use 100% FiO2. There was some shrinkage of the lung, but still we didn't see any suspicion of pulmonary emboli. So we decided to move a step further in these maps, and we realized that the most dangerous occlusion, most suggestive of pulmonary emboli, was some occlusions happening in the lower lobes where perfusion is more abundant. And we realized that blue pixels in the dorsal regions of the lung, they were much more suggestive of pulmonary emboli than ventral blue pixels. And this is why we decided to create an index of pulmonary emboli, of index of suspicion of pulmonary emboli, using the color of the pixel and the location of the pixels. This could be done by artificial intelligence or by a regression model using logistic regression that we did. And then we came to a final score, which I'm going to share with you. So just showing you some other cases. And let's see some examples of this score. For instance, this is bilateral perfusion, completely normal ventilation. The score is negative, so no suspicion of pulmonary emboli. Here, we have a left proximal occlusion, very low perfusion in the left lung, normal ventilation, big dead space. The score was very high. So when this score is above 0, it means pulmonary emboli. When it's below 0, the suspicion is very low. Here it's an intermediate situation because the occlusion was more distal. The score was slightly positive, but not like in this one. Now, to the other side, the same phenomenon. When we have no pulmonary emboli, the score is negative. Distal occlusion, a small number, but positive. And proximal occlusion, a high number, positive. Just to have you an illustration of this index, when the index is above 0, this is a histogram of the index. In blue, we see cases of no occlusion, no pulmonary emboli. So they are our control cases. In orange, we have the cases of pulmonary emboli, okay? And then we see that most positive cases, the index is above 0. A few cases, the index is below 0, and we still had some occlusion, but they were distal occlusions. So, which means that especially for proximal occlusions, the score is always positive. Some distal occlusions, especially when they are very tiny, they could be negative. So, but this discrimination was good enough for clinical purposes. Let's see some examples. And let's compare this score with some other scores that we use, or some other indexes that we use to analyze pulmonary emboli, or to make a suspicion of pulmonary emboli. For instance, this is ventilation ratio. So it's an index of dead space used nowadays to, let's say, as a surrogate of dead space. And as we can see, the correlation is significant, but not that good, right? So, and you could say, oh, maybe the problem is that because the EIT is not good enough. But in fact, when we compare with the angiography results, ventilation ratio, it's a very bad signal for detecting pulmonary emboli, and you are going to see in the next slides. We also compare with alveolar dead space, measured with volumetric capnography. Also bad correlation with EIT and also with CT. So even alveolar dead space or ventilation ratio, they are much worse indexes or surrogates of pulmonary emboli than EIT. Just to give you some feeling about this, this is what happened with your capnograph when you have the occlusion of the vessel. So this is the situation pre-occlusion. This is end-tidal CO2. And then right after the occlusion, we see a drop in the end-tidal CO2, which is going to cause a drop in the volumetric capnography. But this drop is tiny. It's about 10% or 15% of the values. And obviously, you don't see any change in the airway traces, airway pressure or airway flow. So this is the signal that you get with capnography. And when you analyze the volumetric capnography, this is the airway dead space, and the alveolar dead space is this purple area. The blue represents the let's say, the volume of the exhale tidal volume that carries CO2. And the purple represents the alveolar dead space, right? So when we produce pulmonary emboli, we see this change, right? So here we have the arterial CO2, so this purple zone increases. And we measure the size of this purple zone, and we try to correlate with the presence of pulmonary emboli. And then we did also some distal occlusions. Then the change in the end-tidal CO2 is more modest. And the change in the alveolar dead space is also modest, is almost imperceptible, you see? So no wonder that dead space is correlated with pulmonary emboli, but is a very insensitive signal for pulmonary emboli when compared with EIT. And likewise, shunt was also badly correlated. So, summarizing, this is a ROC curve to detect pulmonary emboli in our experiment. In gray, you see the ROC curve related to alveolar dead space or ventilation ratio, right? So an area under the curve is significant, but below 0.7. When we use the global EIT image, so just counting the blue pixels, we improve a lot. So this is already a signal that EIT can be used as a much more sensitive method to detect pulmonary emboli than clinical features like dead space and ventilation ratio. But when we use our regression model, or either elected by artificial intelligence or by regression model or logistic regression, we have a much better area under the curve, almost 0.99. With a good sensitivity and specificity. Sensitivity of 96%, specificity of 94%. And this is when we applied the same model to humans. So this is a test with 232 observations in humans. We still have a sensitivity of 88% and a specificity of 94%. And when we tested only proximal occlusions, we have almost 100%. So for proximal emboli, our method using perfusion and ventilation together and superposing a map of both, and then calculating an index of top of this image gives you a sensitivity and specificity close to 100% for a proximal emboli. So nowadays, this is some clinical examples. This is a patient with pulmonary emboli in our unit, and we can see that the perfusion was completely blocked in the right lung. This patient was very sick, and we decided to do thrombolysis. After thrombolysis, this is the new map, is already bilateral, but you can see that it's bilateral with some delay, but it's still a reasonable perfusion in the right lung. So we consider that this patient was successfully thrombolized. And this is a very interesting aspect of EIT, that you can detect the problem and you can do the follow-up. And for this particular patient, our index of pulmonary emboli was about 2.5. So it was a very, very positive score, as we should expect. Some other researchers have already addressed this problem, and this is a paper from Zhao, published in the American Journal of Respiratory Disease, so the Blue Journal, in 2020. And he also had a good ROC curve to detect pulmonary emboli, but in this particular publication, the number of cases positive or negative were much lower than in our case, and there was no use of artificial intelligence or of logistic regression to analyze the image. It was just a quantification of the blue pixels. But again, just to illustrate that the EIT image is already much better than any other clinical indicator of pulmonary emboli. This is the images of this publication. So Zhao has two publications about the use of EIT to detect pulmonary emboli. This is an interesting case. We can see clearly an arterial obstruction here. And then there is a lack of perfusion in the right lung. And in his case, this gray zone is representing a dead space. So again, this concept of using dead space quantification in the EIT image to detect pulmonary emboli. Some new features about EIT perfusion that is going to help us to have a better use at the bedside. So we know that we have been using sodium chloride 7.5 or 10% for analyzing perfusion. But some people have tested also bicarbonate 8.4 with good results and very similar images of perfusion. So if you have to use bicarbonate for your patient, you can consider to analyze perfusion at the same time. Also, in this particular paper, Marcos and Mauricio Cereda, they are testing the idea of analyzing perfusion without needing or without performing any inspiratory pause, which means something like this. This is the typical perfusion analysis using EIT. We do an expiratory pause, we inject the saline, and we track the signal here for each pixel. But you can do some filtering of the ventilation signal, and without interrupting ventilation, you can also construct this gray curve, and similarly, you can have an image of pulmonary perfusion as shown in this picture. Here, the image is with a pause, so performing an expiratory pause, and here without performing any pause. So very similar images in both cases. We believe that this is going to be the future. So we are going to analyze the perfusion and not using any expiratory pause, despite the fact that the pause is not dangerous per se. is just a little bit cumbersome because you have to do an apnea for 15 to 20 seconds. This image just represents the difference between the two images and is just showing that this difference is very small. So the correlation between these two images was very good. Something that we are now using clinically, we are studying cases of chronic pulmonary emboli, and this is a particular patient with some lack of perfusion in the right lower lobe. We can see here the dead space zone with a positive score for pulmonary emboli. This patient was submitted to surgery. They remove the thrombi, especially in the right side, and after the surgery, we see that the score is now negative, and we don't have any more blue zones in the lower lobe. It's interesting that this intelligent index of pulmonary emboli does not get confused by blue dots in the ventral part of the lung, because he understood and he learned during the training that this could be just dead space caused by PEEP and not by pulmonary emboli. So another case, so we had 13% perfusion here, and after removal of the thrombi, we had 41%. Finally, I would like to share two clinical cases in which we use this clinical tool to solve a clinical problem at the bedside. This was a case published by Fernando Soares-Sipman very recently. So he had a patient with an impairment of perfusion in the dorsal regions of the lung, only 31%. And then he realized that the ventilation was also impaired. And this was suggestive of a bilateral atelectasis. And then he performed a gentle recruiting maneuver. And at the same time that he improved ventilation, he improved perfusion. So this is a signal of a very successful maneuver. But pulmonary artery pressure in this patient was still very high, and then he decided to use nitric oxide. And interesting enough, now that he had good ventilation in the lower lobes, nitric oxide could improve perfusion in the lower lobes, and now he got even higher perfusion in the dorsal regions of the lung. And as a result, he decreased the use of norepinephrine, he decreased pulmonary artery pressures, and he improved venous saturation, venous central saturation. In this particular case, this is another case in which he had a very severe hypoxemia in a postoperative patient, and he was suspicious. He had this clinical suspicion that this patient could have a pulmonary emboli because this patient had received anticoagulation and they stopped because of the surgery. But when he did the map using EIT VQ map, he could clearly see that the problem of this patient was not a pulmonary emboli. There is no blue zones in the dorsal lung regions. The pulmonary index of pulmonary emboli was very negative, and this patient had just had shunt in dorsal lung regions, suggesting atelectasis, postoperative atelectasis. And this was exactly the case. We have some more clinical cases that we could discuss. This is another case of a patient with a very big tumor of the mediastinal region. I'm going very quickly to this case because I would like to allow some time for discussion. In this particular patient, the tumor was obstructing the bronchi tree and also the pulmonary vessels. And the surgeon suspected that this tumor was invading the pulmonary artery. And this was very important because if this was the case, he would like to remove the entire lung. But in this particular case, we did the analysis of perfusion And we observed bilateral perfusion, which means that there was no invasion of pulmonary artery and this lung was preserved. And we can see that the big cause for hypoxia in this case was also caused by shunt and a mismatch between ventilation and perfusion. So more and more cases are being evaluated with this technique, and we can share with you many clinical cases, but let's stop a little bit the presentation here and let's see if we can have some questions from the audience. Thank you very much.
Thank you, Professor Amato, for this insightful lecture here. So as I've mentioned earlier, we would like to open a few minutes now to questions and answers. So please, if you have any question, put the question here under the Q&A icon. You can find it in the bottom of the screen. We already received some questions here. Just let me open. So please, Professor, can you open your camera, please?
Yes. 1 second.
So one of the questions here is if it's possible to perform sequential evaluations of perfusion with the injection of hypertonic saline. And if yes, with what frequency do you recommend to perform these evaluations?
Oh, thank you for this question. This is very important, and I think that this is one of the major advantages of using EIT. In some studies, we have performed up to 6 perfusion evaluations in the same patients in an interval of less than 1 hour. I think this is close to, let's say, to the maximum that we advise today until we have more studies, because you potentially can increase the sodium content, but even in this particular study, in which we did 6 perfusion per patient, the increase in sodium concentration was just 2 millimoles per liter. So it's clinically, this is an acceptable increase. And then I think for most situations, we like to do at least two analyses before and after some treatment, before and after some maneuver that you do at the bedside.
Perfect. There is another question here. Are there any other indications to perform the VQ evaluation rather than only identifying pulmonary embolism?
Yes, I think using more and more this clinical tool, we believe that the image per se can give us a lot of information to solve clinical cases and to do the right approach to the patient. I think cases in which you have, let's say, difficult to understand hypoxia or difficult to understand blood gases are typical cases in which this analysis can help us a lot. Even to detect, for instance, simple cases like just an occlusion caused by secretions or by some, let's say, sudden atelectasis. For instance, many cases in which we just resupinate, so patient was prone, we put the patient back to supine, and a severe hypoxemia, so severe that we had the suspicion of pulmonary emboli, but then when we did the analysis, it was really a complete blockage of one lung caused by secretions. So I think any hypoxemia in which you don't have a good explanation for it could be potentially a useful situation for these two.
Thank you very much, Professor. There is another question here that asking that in the VQ maps, you show there are 3 possibilities: normal VQ, dead space, or shunt. But it is a continuum. So what are the thresholds you took to define these three zones?
Thank you for this question. It was an empirical threshold. We use 0.5 for low VQ, which means that we have 2 times more perfusion than ventilation. And then we use 2.0, which means that we have 2 times more ventilation than perfusion to say that this is a blue zone, mostly ventilated. These obviously, we could use a higher threshold, but we empirically found out that these thresholds, they correlate very well with most clinical conditions. We know that a true shunt means that typically the ventilation to perfusion ratio is below 1/10 true shunt. But in our case, using this threshold of 0.5 is useful to detect very low, let's say, low ventilation to perfusion areas. And this is enough to cause hypoxemia in patients with ARDS, for instance.
There is another question here that if there are any studies in children that evaluates the distribution of perfusion, and if there is any recommendation to normalize the saline volume according to the body weight.
Yes, this is a new field. There are some preliminary studies using saline in children. And indeed, what we are trying to do is to find a ratio between body weight and the amount of perfusion. So for instance, if you consider more or less, we are testing animals and also in some pediatric patients, the following calculation. So for each, for instance, an adult with 40 kilograms, we use 10 mLs. So for a small baby, I would use the same concentration, but a lower amount of saline. So for instance, a kid with 4 kilos, I would use 1 ml, something like this.
Another question that we have here, Professor, is asking about pulsatility. So measuring the perfusion distribution with pulsatility when compared to injection of the hypertonic saline. What are the differences between those two methods?
It's very important to state, and this was already stated in our paper of 2013, that pulsatility is not perfusion. Pulsatility is in an index that reflects two properties, two physiological phenomena: the stroke volume of the right heart and the elasticity of the pulmonary arteries. And then it can be, and in some situations, it reflects much more the change in stroke volume, and in some other situations, it reflects the change in the pulmonary vessel elasticity. And when you try to do a correlation with pulmonary perfusion, the correlation can be very poor in many circumstances. So we do not recommend to use pulsatility as a surrogate of perfusion. Indeed, this is very important because there are some papers and some advertisement of the use of pulsatility to do online and real-time analysis of perfusion, and this does not work.
Thank you very much, Professor Amato. So our time is reaching to the end. So before concluding today's session, I just would like to leave you with a thought from Joran Hendesterna, who once said that a bedside tool capable of measuring regional perfusion and regional ventilation would be worth waiting for. And today, it's extremely incredible to see how far we can come towards making the vision a reality. So with technologies like EIT that now shows how can evaluate both ventilation and perfusion at the bedside, allowing us to tailor treatment more precisely for each patient. So thank you very much, Professor Amato, for sharing your invaluable insights with us. And thank you to everyone who is here that is committed for advancing patient care. And we know that together we are turning Hendrik Sterna's vision into practice. So thank you, everyone. Thank you very much again, Professor Amato.
Thank you,
and
Nato.
I hope that all of you had enjoyed this meeting. We will have a recording that will be available to all of you soon, and we will send you a link by email. Thank you again, and have a good evening.
Thank you, and I fully agree with this comment of Joran. Bye.